Welcome to the Better Beth podcast. I have the very lovely midwife and lecturer, Kelly Sawyer, back on because she's been on the podcast a few times and keeps lovely coming back. Welcome, Kelly.
Hello, it's lovely to be back. Is this the fourth one we've done?
I think so, yeah.
Gosh.
But your episodes are so good. They're the ones that I like signpost all my clients to. Like this is a list of all the essential ones you have to listen to out of the hundreds. And yours make the cut because they're always really, really well explained and backed by evidence and research and with a little hint of a rant in there, which is what I like.
Yeah, I love a rant, so I'm here for that.
And I'm suspecting there's going to be rants today because we're covering and we're going to be talking about growth charts today, aren't we?
Mm-hmm. Yes, yeah. So there'll be lots of rants, I'm sure of it.
Absolutely. But the reason I picked this topic is because I had kind of this realization that I think a lot of people, well, everybody pretty much, unless they opt out, will go for growth scans and they have fundal height measurements and they have their babies plotted on these charts. And actually, most people don't know what these growth charts are and what they mean and what the readings actually could mean in terms of implications for their birth choices and birthplace options and potential recommendations for intervention. So actually, I think it's a really important topic that we cover. Mm-hmm. The first person I thought of was you to help me explain what a growth chart is. So shall we start like right at the beginning? Let's go right back to basics, assuming that people that are listening do not know what a growth chart is. Do you want to explain what the growth charts are that they will probably see throughout their pregnancy?
Yeah, so if we strip it back even further and thinking about what this is and why we're doing it. So it does what it says on the tin. It's a growth chart. It measures what we believe to be the growth of the fetus during pregnancy. And I will start with a big caveat, and I'll have to say it now in case I forget to say it later. We do not know. We will never know what a baby weighs while they are in the uterus. We never know until that baby is out in the world and on a set of scales. That is the only time we know. Everything before that is a guess. An educated guess, but a guess at best. So what this sort of obsession comes from, because we are very obsessed with the size of babies in the UK. It's one of the first questions new parents get asked when their baby is born. How much does it weigh? And it's such a weird question. But the reason why we are a bit obsessed with growth during pregnancy is because there is a very strong link between babies that are smaller than we would expect or not growing to their full potential and babies that sadly are stillborn. And what we're looking for is fetal growth restriction. It's quite rare. It only affects between 5 to 10% of pregnancies in the UK. And that is a baby that is struggling. It's often these babies are sitting around the 3rd centile, and we'll talk a bit about what centiles mean and stuff in a bit. But often this sort of small growth is accompanied by a problem with the placenta and a problem with the blood flow in the cord to the baby. So the baby's not getting the right amount of oxygen and nutrients that it needs to grow to its full potential. In the same way that is if we didn't eat anything, we wouldn't keep growing.
Yeah.
So it's that same sort of logic. So those are the babies that we're looking for. And fetal growth restriction causes up to 50% of stillbirths that happen before 34 weeks. So it's a huge, significant link. So that is the reason why we are really keen to get at least an idea of where this baby's at during the pregnancy so that we can intervene before we do sadly have a stillbirth. But again, everything will always come back as a caveat. This is quite rare, and as with any kind of intervention in maternity care, we often go too far with it. So it's really important that we do it, but it's also important that we use that information correctly. And unfortunately, again, as we'll talk about in a bit, I'm sure, it often gets sort of misinterpreted and interventions get thrown around a bit too laissez-faire. But ultimately, this is what we're looking for. We are monitoring growth during pregnancy to spot these babies that might be in trouble and could potentially not make it if we don't step in and do something about it.
Yeah. And while we're talking about fetal growth restriction or intrauterine growth restriction, so someone might see it abbreviated as IUGR.
Yeah.
This is not the same as a small baby that's just
No.
small, is it?
No.
Because, I mean, I've said before on previous podcast episodes, my children, all three of them were SGA babies, which stands for small for gestational age. That doesn't necessarily mean you've got a growth restricted baby, does it?
Absolutely. So there are sort of three different types, and you'll see lots of sort of abbreviations and stuff thrown around. So the three sort of small babies that we have is your first is your normal small, your constitutionally small is what we call it. So that was your babies, Erin. That was a small baby who has been created by a small mum and dad. They are just going to be small in the same way that not every adult is the same height, same weight. Same goes for our babies. There will just be some babies purely genetically are just small and they're absolutely fine. That placenta is working really well. It has a consistent growth. It might consistently sit around the sort of 12th, 13th, 14th centile, and that's absolutely normal for that baby, and that baby is loving life. Then you've got your SGAs, so as you said, small for gestational age. Those babies tend to sit around or below the 10th centile. And just to explain it, just in case, I don't want to patronize anybody, but the centile thing, what that means is if a baby's on the 10th centile, it means that 90% of babies born at that gestation are bigger than this baby and 10% are lower. So that's what that means. So the majority of babies are bigger than our 10th centile baby. SGA babies they're a bit on the fence. Some of them could fall into that normal small category, but some of them could be at risk. So they will probably need a little bit. You probably had extra scans and stuff, Erin, in your pregnancies. Just keep a little bit of an eye on them. We can do Doppler studies, so sonographers while during the scan, can actually look at the blood flow through the cord to see that that's all okay. So that will be something that's probably offered to somebody with an SGA baby. But again, that might just be normal. It's also worth noting or being aware that a baby is SGA during pregnancy, because they might need a little bit of extra care postnatally. So they might need to be kept really need to really keep them warm because they're small and they've got a bigger surface area. They'll lose heat quicker, so we need to be really conscious of that, and also beefing them up with milk, however that baby's fed. Keep making sure that their blood sugars don't drop too low because they're a little bit smaller. So it's worth sort of having that in the back of our minds before baby comes out. So those SGA babies, a little bit on the fence, could be at risk, could not be. But yeah, they're ones for us to keep an eye on. And then our fetal growth restricted babies are the ones, as I said before, that we're worried about. Those babies sit around or below the 3rd centile. So 97% of babies are bigger than these babies. So they are quite teeny. And the Royal College of Obstetricians and Gynecologists say that actually fetal growth alone is not enough to diagnose fetal growth restriction. It has to come with abnormal Dopplers. So when the sonographer is looking at the blood flow through the cord, there is a problem. So we know that there is a placental issue going on there, or some kind of issue with blood flow or nutrients and oxygen getting to the baby. So you're completely right. Just because you're being told your baby is small does not mean that the world's going to end and the baby's going to die and everything's going to be terrible. It could just be normal.
Yeah. And like you said earlier, like genetics plays a part, right? And ethnicity, your ethnic heritage, your height. I mean, I'm 5'1". I'm never going to have 6-foot babies because that would be impossible genetically. And because I'm Chinese as well, or mixed heritage, I'm more likely to have smaller babies. And I just want to point out, I know we're talking about during pregnancy, but these growth charts follow you into your red book that you get afterwards, and it can be easy to become obsessive about your child's growth after they're born and outside of the uterus. And all of my children, like my Daisy, dropped off the bottom of the chart completely.
Aww.
So she was on the 0.4, and then she was like off the bottom of the chart, and she's still very, very tiny. And that's just her. That's just her genetics. She's 9 and she's the same height as some of the 5-year-olds in her school. And she's just Diddy. So I just wanted to kind of point out that these growth charts are not just during pregnancy. They will also continue to, measure and weigh your child just to make sure that they are growing, as they should be postnatally as well. But during the antenatal period, there are certain points where these measurements are taken, aren't they? So do you want to talk a little bit about where we get these kind of measurements from that we plot on the growth charts?
Yeah, so going back to when I trained quite a while ago, what we used to do is offer fundal height measurements. So use a paper tape measure, and we measure from the top of the uterus down to the pubic bone, and that's offered at every appointment. And roughly, it's quite clever in that roughly it should equate to dates in centimetres. So if somebody's 28 weeks pregnant, it should roughly be about 28 centimetres in measurement, give or take 2 or 3 centimetres either way. And what we used to do, we didn't have charts back then, we used to just note down how many centimetres somebody was and watch that trend progress during the pregnancy. So if somebody was always hitting 28 weeks, 28 centimetres, 32 weeks, 32 centimetres, but then at 34 weeks, they were suddenly still 32, or
Yeah.
it wasn't quite following that trend, then we might offer a scan at that point.
Mm.
What we then also started to see was growth charts sort of being developed, but every single person was put into one big pot, and we created a one-size-fits-all approach of having a one-set standard, which is exactly as you were saying, Erin, what you see in the Red Book. There's just a one-size-fits-all chart. This is how babies should grow, full stop. But we understand, as you were saying earlier, Erin, things like height, weight, BMI, ethnicity, and just generally, if just genetics in general, all have a really big part to play in how we grow our babies. So what a lot of trusts have adopted now is a program that was devised by the Perinatal Institute, which is called GAP. And what that does is tries to take on that little bit of common sense that you were talking about, Erin, in thinking about those factors and how they do affect fetal growth. So what often happens now, I think something like 70% of NHS trusts in the UK are using the GAP program or some sort of equivalent. What will happen at the booking appointment is that the midwife will note down your height, weight, your BMI, your ethnicity, and also any previous children you've had, what their sex, gestation, and weights were. Because somebody actually could be quite petite and small, but make a big baby and birth that baby absolutely fine, and that baby was fine. So that's also nice to know. And the Perinatal Institute database contains data from over 2.5 million pregnancies, so there's a lot of data in there, and it sort of takes your info, churns out a customised growth chart that will be specific to you. So if you were pregnant now, Erin, your growth chart would look very different to mine. I'm Caucasian, I'm 5'9", I'm size 16, I'm a very different build to you, and our customized growth charts would reflect that difference, because we would grow completely different sized babies. And so when we are doing those measurements, what the guideline is from the Perinatal Institute is that we start those measurements around 26, 28 weeks of pregnancy, when a bump is starting to show for most people, and we offer measurements every 2 to 3 weeks up until birth. For some people, fundal height measurements don't make sense. So if it's a twin pregnancy, for example, they grow very differently to a singleton pregnancy. If someone's got big uterine fibroids that will really distort the uterus, that then doesn't make sense. We're measuring that too. And they also say raised BMI over 35, they wouldn't offer it as well, which I think is a bit silly, because BMI in itself is really silly, and we could talk for another 2 hours on that, but that doesn't tell you how much abdominal fat somebody has. But the idea is that if someone's got a lot of abdominal fat, it wouldn't make sense to measure like that either. So they would be offered serial growth scans. And if there is any kind of a problem, so if the baby's following nicely a consistent growth on, say, the 50th centile, which is what they consider to be optimal growth, that's bang on average. If they're following that, for example, and then it goes off of that, either accelerated growth or decelerated growth, then you might offer a scan at that point to see what's going on, to be a little bit more accurate. So that's kind of how it works.
And we also have there's at least 2 scans
Yes.
as standard, a 12 and 20-week scan. And again, one thing that I think is quite important to note, that some trusts offer an additional scan round about, is it 34, 35 weeks?
Yeah.
Which is kind of third trimester, and that may be useful in some cases, but also in some cases might be slightly problematic. Do you want to just talk a little bit about the scans and accuracy of scans and their trimester scans?
Yeah, so when we're thinking about the sort of hierarchy of accuracy, if you like, we've got fundal height measurements at the bottom. Fundal heights are quite subjective. You could have 3 or 4 different midwives all measure the same bump and get a different measurement.
Yeah.
Same with VEs. We talked about that in a previous podcast episode. It's very, very subjective. So, and it's not very accurate. If someone needs a wee, if they're feeling a bit bloated or whatever, the baby's position as well could really alter that measurement. So there's lots and lots of, it's open to human error. Also, midwives have to plot that measurement manually on this graph, and often if that's just looks a little bit skew whiff, they've done it a little bit wrong, it knocks the curve off, and that could spark a whole thing. So there's so much human error that is involved in fundal height measurements. I worked with some really brilliant fetal wellbeing midwives at my last trust, and the way they described it was so good. They said if you're doing a fundal height measurement, you're measuring the house, and a scan is measuring the occupant. So when you're doing the fundal height measurement, you are measuring the water around the baby, the placenta, the baby, any fat that's there, or everything. Whereas a scan is looking particularly at the baby itself. And that's great, and that gives you a little bit more accuracy. However, if baby's in an awkward position, it really throws it off. Generally, there's about a 15% margin of error with scans, which is actually massive. So if, say, for example, a scan predicted your baby was going to be 4 kilos, which is 813, just under £9, it could be anywhere from 3.4 kilos, which is £7.8, all the way up to 4.6 kilos, which is £10.2, and that would still be considered acceptable for the scan.
It's a huge window of error. That's like massive.
It is enormous. Enormous. So again, take scans with a bit of a pinch of salt as well. There was a big Cochrane review. Cochrane reviews are like the holy grail of research. They look at all of the research on a topic and sort of give you a summary of it. They looked at whether third trimester scans were useful, and they found that there wasn't any use in a low risk pregnancy. So they have recommended that they shouldn't be offered routinely in low risk pregnancies. However, some studies have found an increased detection rate of fetal growth restriction if a third trimester scan is done. So it's personal choice, I would say. I mean, in the same as any other scan or fundal height measurements, everything is an offer. And if you don't want to have it, you can absolutely decline or ask them their rationale as to why they're doing it and what they're going to do with the results. So don't feel like you have to go. It is always nice to see baby. I had quite a late scan in my pregnancy, and it was lovely to see baby up there on the screen. But actually, it's about sort of being armed with, actually they might tell me baby's breech or baby's huge, or and you know, put the fear of God in you. So there is always that potential. So I would say, you know, if you have a low risk pregnancy, it's really not going to give you much, really.
Yeah. And you mentioned huge babies. I think that's one thing we haven't talked about, which we have to, because we can't really talk about growth charts and not talk about suspected big babies, because that puts the fear of God in people if they're being told they're having a massive baby. And I, in my experience, the third trimester scans can often pick up a suspected big baby that actually isn't big, and then you're on that kind of conveyor belt of induction, get the baby out earlier because your baby looks massive, and then the baby's born and you've had potentially a not very positive birth, with all the interventions that can come with an induction, and your baby's not massive. So what's your views on the big babies?
Okay, ranty pants are firmly on now. So, so as I said before, we are doing this to pick up babies that are at risk of dying. A large baby is not at risk of dying. There is obviously risk that comes with a large baby. There are things like shoulder dystocia, where the shoulder gets stuck on the maternal pelvis on the way out of birth. There are more likely to have perineal trauma because it's a bigger baby coming out. You know, postpartum hemorrhage is a bigger risk with a big baby. There are risks involved, and I'm really not downplaying it. If somebody with your build, Erin, was growing a 10-pound 11 baby, I would be terrified for you. It's, you know, I'm
So
not.
would I.
You know, I'm not downplaying it whatsoever. But the GAP program, or the customized growth charts, the whole surveillance of fetal growth, the main purpose of that is to pick up our fetal growth restricted babies. It's not to pick up LGA or large gestational age babies. There isn't any clear guidance for that reason from the Perinatal Institute about what to do if you think that there is a big baby brewing in there. So that is often left down to local trusts to decide. We know that generally we are becoming more interventionalist in the UK when it comes to birth. So we know that often it is a offer induction, think about it later kind of mentality. We know from research that often the fear of a big baby is enough to cause a bad outcome, even if the baby is a normal size. And you can see it and you understand it. You know, if someone tells you that you're going to birth a 10-pound baby, you're going to be terrified, and that's going to not give you all that lovely oxytocin, lovely love hormones that you need to labour effectively and well. It's just not. We know that shoulder dystocia is very, very common in normal sized babies. We know that if somebody is, you know, sort of low risk, non-diabetic, the chance of them growing a baby that is not going to fit out of their pelvis is really, really small. It's only in those cases, particularly diabetes, where growth is unstable, that you might end up growing a baby that isn't going to fit out of you. But for the majority of people, vast majority of people, they're not going to make a baby that is not going to fit out of their pelvis. So yeah, it really irks me, because I think all of us who are involved in birth work in any way have at least 5 stories of people that have been induced unnecessarily for a large baby and out popped a 7-pounder after, and that, as you said very rightly, that parent or those parents are then left with birth trauma. It really does irk me, because as I said at the very beginning, we never ever know what that baby's going to weigh until it's in the world and on a set of scales. Before then, it's a guess.
Yeah.
So
and,
yeah.
And even if they are big, it's not necessarily an issue.
No.
Like, just the same as my babies were small, and that was due to genetics. And I birthed my babies absolutely fine, and they were absolutely fine when they were born. If you are genetically predisposed to having a big baby, it isn't necessarily an issue. And you mentioned shoulder dystocia earlier. You're right in that, you know, any size baby can experience shoulder dystocia. And also what we're trying to prevent with the shoulder dystocia is nerve damage to the baby. And actually, it would take 3,000 C-sections. I'm trying to remember the stat now. 3,000 C-sections to prevent one or two cases of permanent nerve damage due to brachial plexus palsy. So I think when we're thinking about the things we're trying to prevent with a big baby, and actually looking at the likelihood of those things happening, and I say this all the time when it comes to induction, and weighing the risks of the induction process itself, people need to be informed of what the likelihood of these things are in order to make an informed decision. And I think a lot of the time with big babies, people are just terrified by their care provider that they're having this big baby and it's going to cause damage to them and their baby, and they end up with quite a traumatic birth, I think.
Yeah, I agree, because especially if it's somebody's first baby, you just don't know what they're going to labour and birth like and what their pelvis is capable of doing. You just have no idea. So as we said, you know, somebody who is actually quite petite might have a history of big babies in their family, and all of their sisters might be the same sort of build and all birth big babies, and they were a big baby at birth and their partner was a big baby, and actually that's fine and that's normal for them and their family, and they don't have a problem. But we jump in and we convince them that they're going to have a problem, and then we intervene, mess up their birth, and then make them terrified of birth in the future if they have any more children. So yeah, as much, it has to be a case of we have to be honest about the risks that are associated with induction of labour, because it's not a risk-free solution to the problem of women's bodies being broken, because that's essentially what the system thinks. The system thinks that we're all defective and that the medical system has to come in on a white horse and save everyone. And unfortunately, that's not true. We have been birthing baby for millennia, and we can carry on doing it. We're not, the cesarean section rate now is so astronomically high. We're not suddenly more broken than we were 200, 300 years ago, or even less than that. Even in the 60s, 50s, the cesarean section rate wasn't this high. We're not defective. And we're not growing babies that are too big to get out of us. We haven't devolved as a human race. We just haven't. So as much as that is where I stand, but obviously it has to be an individual thing. If you are 4'11" and all of your scans and all of your measurements and everything's coming back that your baby is possibly going to be 10 pounds, and you feel massive and something just doesn't feel right about what's going on, because we often forget that as well, that the birthing person's intuition and what they feel in their body. I was told when I was pregnant, I was told really early on that I was growing an elephant. I was 28 weeks pregnant and they measured me as 36 centimetres. It was off the scale. It was nowhere near the 100th centile. It was up in the God somewhere, this measurement. And I just knew that was crap. I just knew it was instinctively.
Yeah.
I didn't even look pregnant at the time. It was such a weird thing. And my baby was not an elephant. So yeah, nothing that we do in pregnancy is ever going to predict it or get it 100% right. So if you are having all of these thoughts, if every measurement is coming back that it's massive, if you instinctively feel that it is massive, you can hardly move, then if you feel at that point that an induction of labour or an elective cesarean, don't forget that you can opt for that as well. You haven't got to go down the induction route. You don't have to do it if you don't want to. If all of what they're telling you adds up to how you feel and what's going on in your pregnancy for you, and you want to intervene and birth that baby before they're coming out naturally, that's absolutely fine. But just, it's about being aware that we don't know the answers and that you have to go with what feels right for you, and don't be scaremongered, basically, which is easier said than done.
It is. I think, at least myself personally, having information to help with that decision making is really important. And I think, again, this is why I'm so grateful for you to coming on today and talking about this, because I think a lot of people are fear-mongered into intervention because they're told they're having a really small baby, or they're having a really big baby, or the baby's growth is declining or it's accelerating. And we have to look at these. You have to look at your own individual circumstances, because unfortunately sometimes the people that are caring for you or supporting you in your pregnancy aren't applying that context and, quite frankly, common sense. I think it's important that as a pregnant person you're well informed to apply that common sense and context and evidence and understanding about what's going on, so that you can decide what you want to do, because ultimately it is a choice, right? All of it is a choice. Whether you have fundal height measurements is a choice. Whether you agree to scans is a choice. I know I've had clients who've had wild pregnancies. They didn't even know if there was more than one baby in there because they had no scans, they had no fundal height measurements, they didn't see a midwife once, and they free birthed. Like, not everybody's choice, but it is a choice. And you can't make those choices, I think, if you're not well informed on what it is that you're consenting to or declining. So, as always, it all comes down to choice, I think, and informed choice is best.
Yeah, absolutely. And just not being coerced into a decision that actually you don't want to make, because it's you that has to live with that decision making for the rest of your life. And if actually it does lead, you can never predict the future. I really wish we had a crystal ball sometimes, but if you can feel happy with your decision making regardless of the outcome, then you've made the right choice for you.
Yeah. You have such pearls of wisdom to share. I'm going to have to think of another topic for us to come on and talk about, because every time you record a podcast, maybe I'm like, oh yes, this is good stuff. is there anything that we've missed that we should have talked about with growth charts and growth measurements that we haven't covered before we finish for today?
Nothing is coming to mind. I mean, I think the important thing as well to note as well that growth isn't always linear during pregnancy. So
Yeah.
I wouldn't jump into a decision on the back of maybe one measurement or one scan.
Yes,
I would
that's a really good
definitely
point.
try and as long as it's safe to do so, to try and give it a bit more time to see, because actually that baby might have a growth spurt and sort of catch up with itself and go back to the curve it was on before if there was a bit of a problem. So I think it's important to remember that and think about that. It's also worth bearing in mind that if your healthcare professionals thought your baby was so desperately at risk, they would offer you a cesarean right that second. They wouldn't be talking about things like induction necessarily. You know, it's important to bear that in mind too. And also, as well as we were saying, you know, to think about having an additional scan or additional measurement or giving it a bit more time to gather a bit more information. You know, ask for Doppler studies if they haven't done it already. So ask for Dopplers for them to look at the blood flow through the cord if they haven't done that. Because as I said, that's really important to pick up a placental issue, you know, a baby that's at risk as opposed to a baby that's just normally small. And also things like, you know, I know we don't like them really, but CTGs, you know, there's lots of other things you can do to check on the welfare of this baby. And, you know, when you go for a scan, they'll look at things like the Lycor volume as well to make sure that that's all okay. You know, they'll have a big holistic picture. So take everything into account. You know, it shouldn't just be, this is the estimated fetal weight, so we're going to offer you induction right now. You know, it has to be looking at the bigger picture and always remembering your instinct, because I feel like antenatal care is life-saving and it's brilliant, but it does slowly chip away at your power. It takes away your power. You might feel really well in pregnancy, but someone tells you that you're not. Same with in labour. You think you're in labour, someone comes along and does a B and says, oh, you're 2 centimetres, you're not in labour. We chip and chip and chip away at women's intuition and power when they're pregnant. And then sadly, postnatal care is so diabolical in the UK that we kick them out and say, off you go, bye. And we've taken away all that autonomy and left them with this child to look after. And it's so overwhelming and scary. But that's another podcast episode for another day.
That's another topic.
But, you know, sadly that does happen. So don't surrender all of your power to charts and measurements and tests and exams and scans. Don't give all of that away. Maintain some of your intuition, what feels right for you, your gut feeling. All of those things are really paramount as well. And actually, you need to work with that too. It's not at the bottom of the rung of the ladder of hierarchy of things that are important when making a decision. It isn't equal. So definitely, if you want the test, take the test. If you don't want the test, don't take the test. But also throw in a big, heavy handful of salt into anything that's been told to you, because we just don't know. Yeah.
Ah, thank you for coming on and talking about that. It's been amazing and really informative, I think. And I now my brain's churning of all the little sound bites that I can take out of everything that you just said. And I'm going to think of another topic that we can talk about on another day, because you're amazing. Thank you.
Oh, no, thank you. And thank you so much, Erin, for everything that you do to help empower it and inform families, because it's really important, and you're doing really great work. So thank you so much for everything that you do.
You're welcome. Thanks, Kelly.
Thank you.